Hey Deb, thanks for joining me today.
My pleasure.
So we're here as a part of the PA Foundation. Do you want to tell them more about our purpose and what we've been working on these last couple months?
Sure. Our purpose as part of the PA Foundation is to educate our peers about prescription opiate misuse in special populations and how they intersect.
Sure. And for this conversation, I think we're supposed to focus specifically on LGBTQIA and young youth and young adult patients.
Yes.
Other portions of our program, we discuss this population as well as others in more detail. We all know that LGBTQIA youth are an especially vulnerable population. They face a lot of challenges and risk factors that we really need to focus on as healthcare providers.
Exactly. Absolutely. Brittany, why don't you tell us a little bit about the area in which you work in?
Sure. Well, right now I work, in addition to my responsibilities at University of Maryland, Baltimore, I work as an urgent care and primary care provider in the areas around Maryland. I started off as a primary care provider, which I thought was amazing and really gave me a lot of purpose. I then bridged into hospitalist, and then I found myself here where I deal with the spectrum of health conditions. Why don't you tell us what kind of sparked your interest in this specific population?
Well, as a PA for 40 years, my first 19 years was in the emergency room, and I just always wanted to give back to the community, so I started looking for community centers to work in. And I started about 15 years ago at Chase Brexton, where I wanted to really give back to the marginalized LGBTQ community. And that's when I met my mentor, who was the chief medical officer at the time, who was the only person who specialized in transgender medicine of the child and the adult. And since then, I've grown to be expert in that field, and it's been gratifying, and I feel grateful every day for the opportunity to make change and differences in their lives.
Wow, that's amazing. So Deb, being as you specialize in dealing with this at-risk population, what makes this population so vulnerable?
Well, every day, Brittany, I'm faced by these children with their parents who feel desperate for help. I can feel within their parents and their spirit that they really want help for their children. They see their children living lives unhappy and not able to be part of normal life and mainstream schools, just being rejected by their friends, classmates, siblings, maybe even parents. But at the same time, looking with hope that they can get help so that they can live authentic lives. You wouldn't believe still in 2022 how much bullying happens in schools, how much teasing. Data and studies tell us that there's still a lot of up to 79% harassment because of a person's sexual orientation in middle and high schools. How 40% of LGBTQ youth are homeless because their parents put them out for trying to live their authentic lives. My patients who are transgender, who struggle to live and walk truth as that gender that they align with, really struggle. They're one of the most misunderstood group of people, and all they want to do is just live happy lives and to be understood. So it's not surprising to me that they live such a life where misuse of opiates are self-medicating and are coping mechanisms for them.
Sure. So as a healthcare provider and maybe other persons that may intersect with this specific population, what are some misconceptions we should be aware of?
Well, first of all, the misconception, because LGBTQIA medicine is not taught in any curriculum actually, the common myths are, well, LGBTQI people have mental illness. They were sexually assaulted as children. They grew up in environments that weren't really receiving and accepting of them, where we know that as LGBTQI kids really do know their gender identities and sexual orientations from early on in life. And it has nothing to do at all with the neighborhood that they grew up with, the impact on their parents, how much money, economic status, religious beliefs, but that the anxiety, depression, and substance use disorder actually does come from the way they're being treated and rejected, and the discriminations and lack of being accepted.
Sure.
And I just know that there's nothing traumatic in a person's life. The divorce of parents or sexual assault, they can change a person's sexual orientation or gender identity.
Wow, that's a great point.
So, Brittany, in my practice, I know that the majority of my patients are going to be LGBTQI, but you work in an urgent care center. What strategies do you use to identify this group of people in your practice?
Sure. Well, as a center, we've definitely made strides to do better. From the point of registration, kind of asking how a person identifies and if they have a preferred name. But like many institutions, this is in the very beginning stages. So when I go into a room and introduce myself and how I would like to be referred to during the visit, I do the same for my patients. Ask them if they have a preferred name and how they choose to identify.
Tell me, do you feel that you treat these patients any different than you would any of your other patients?
So for any vulnerable population, LGBTQIA, youth and young adults, you want to create an environment where they feel safe and comfortable to have conversations that frankly are not comfortable. We ask completely invasive and unnatural things when someone's coming in. And in the urgent care, I don't have a rapport with people. They don't know me, but I'm coming right in and asking them, like, so you think you were exposed to what? It's really important for me and other parties that are practicing a similar type of medicine to create an environment where people feel welcomed and they feel like they can have these conversations and they're not being judged. And it comes to mind a patient that I did have. They were male at birth, female identifying, and they talked about the experience they had at the hospital. And I guess it was on the chart as one thing, and she really felt people came into the room unnecessarily, asked really invasive questions that had nothing to do with the visit, that they were examining genitalia inappropriately, things that really created an environment that was anything but comfortable, to the point where she didn't want to go to the hospital anymore. So it's really important for us to keep this in mind, that the things that we do during the visit can completely change someone's perspective on healthcare, can make them feel that they definitely have a safe place to go or not. Increases risk even more so for the population to self-medicate if you don't feel like you can go to the people who are supposed to be providing quality care.
Good point. I often hear that from providers that I may train or teach, that
Sure.
We're just given 20 minutes. You work in an urgent care center. You have people coming in. You never know how fast and how often people are going to come in, and you may be very limited with time. How do you navigate those questions in such a short period of time?
100%. We are definitely not giving a plethora of time, but when you become more comfortable, you realize that doesn't mean that you have to rush someone's care. And even if someone's like I have patients hang out of the rooms, like how long is it gonna be? But in real life, like I said, you have to take each conversation and interaction separately and treat them like they're important. I realize the limitations of the visit, and I express that to the patient as well. But I might be the only person that they feel comfortable having a conversation with. So I encourage them to follow up with me if they would like to, and have resources available to them, so that way we're not like scary and trying to find a business card. I know that certain places may be more inclusive and comfortable, so I provide that information to the patient so that they can know that they don't just feel safe here, and this is not the only place you can go to, but there are other places as well.
So, Brittany, I know that all of your patients, or all of the patients that come to you, are not complaining of pain. Is that a concern for you?
So in dealing with LGBTQIA and dealing with youth and young adults, it's always important to have a community and an environment that's welcoming, not just if you're here for pain. Pain is hard, but the reality is there's different kinds of pain. And even if someone's not saying they're in pain, they might be in pain.
That's true.
I think about the Maya Angelou quote that talks about how people won't always remember what you do, but more so how you make them feel.
I like that.
So as a provider, it's really important for us to carry that with us. And sometimes they come in and they're like, I'm really concerned about pink eye, but realize that, wait, I actually feel pretty comfortable in this room. So while I'm here, can I also ask you? So leaving that environment such that this person feels welcomed and comfortable to say these kind of things and to have these kind of conversations is always super important.
Awesome. I agree. I hear so often in my practice how mistreated and disrespected my patients are when they go to places like urgent care centers. So I really
No, I'm just
appreciate
kidding.
So I appreciate you saying that that you take the effort and that your center takes the effort.
Yeah, we do have to do better. And as a community in general, treating people like people. At the end of the day, we all have issues. Everyone can have a bad day. So kind of putting our concerns to the back and putting the patient's concerns as first.
That is important because one of the things also that I hear is that, you know, it doesn't make sense for me to go there anyway. They're just going to say bad things. They're going to treat me wrong. They're going to be negative. And just feeling that positive spirit coming from you makes all the difference in the world.
Oh, thank you so much.
You're welcome.
So Deb, what common pain complaints do you deal with your patients?
Well, one of the things that we do know about LGBTQI youth is that the microaggressions that come from the stress of discrimination and rejection leads and causes anxiety and depression.
Sure.
And people waiting for the shoe to drop. We all know that cortisol reaction, that fight or flight.
Yeah.
But what I hear is I hurt. Everything hurts. Everything hurts. My head hurts. Nobody can tell me why my head hurts.
Sure.
The x-rays aren't telling me why my head hurts.
Sure.
My stomach hurts. Everything. I have pain all the time. And I've gone to several specialists and no one can help me. And so we know about certain tools to use so that we can determine whether a person is struggling from anxiety, depression, or emotional pain, and are able to better address those pains.
Sure. That's really important because as an urgent care, and unfortunately patients may feel dismissed if I try to have that conversation. So tools to have these difficult conversations are so important. People are like, I've been to 6 specialists for my stomach and it hurts. I know that it hurts. No one can tell me that it doesn't, but no one can tell me why. So how do you actually go about having that conversation with the patient?
Well, I tell you, it's really difficult when a person goes in and they're being told, it's all in your head. Go to therapy, go to counseling. It's your imagination, when I know that what they're really having is chest pain, or what they're really having is abdominal cramping that's coming from that stress.
Sure.
And so just to be able to listen and to be understanding and to know that I'm not going to be able to treat your anxiety, depression, any emotional stress that you're experiencing if I don't help you first cope with your coping of the rejection, of the discrimination.
Yes.
And the feeling that people are hating you and not wanting to be supportive.
Yes. So I think that's a really good point. Just validating the symptoms.
Yes.
Saying, I don't doubt that this is real. I don't doubt that your stomach hurts, and I don't doubt that you have a headache. But what I'm telling you is that maybe it'd be easier to approach dealing with it if we actually deal with all these other things.
Yes.
And sometimes I even say, like, I can't imagine what you've been going through, but I empathize with you. And even with what I go through daily, things are hard and sometimes things hurt for me. So I'm sure that this pain is 100% real.
And, you know, for us as practitioners, we really have to, you know, validate, you know, humble ourselves.
Sure.
We don't know what it's like to be in your shoes, to look through your lens. Can you tell me how it makes you feel?
Yeah.
And please tell me how I can support you, and tell me how I can make you safe, so that I know until we work through some coping mechanisms to help you to be in a better place, that you'll be safe with opiates or alcohol use or nicotine or whatever is causing you to use these as coping mechanisms to help you to feel better and happier about yourself.
That's a great point. So Deb, do you have any experiences that you would want to share?
Well, unfortunately, I'm seeing more and more middle and high schoolers that are abusing, misusing pain medications. And it's scary for me because the counterfeit opiates, oxycodones, look just like the authentic ones.
Yeah.
And they're just loaded with fentanyl. And we're hearing more and more every day of 15-year-olds dying. I have several, I shouldn't say several, but I do have a trans female I was just talking to in an office visit last week about, I use opiates, I have to use Percocets, I have to use, because it makes it easier for me when I do sex work. And as a 13-year-old, nobody wants to hire me. And so I have to do sex work in order to survive. You know, I use the money for hotels and to get food and to get clothing for myself.
Wow.
I had another kid that was 14 that said, you know, none of the kids ever say, I'm using it to get high.
Sure.
But this kid said, it makes me sleep.
Yeah.
And I can sleep for hours. And when I'm asleep, I don't think. And sometimes I think that I might not wake up.
Sure.
So all of these are just really hard to hear.
Very.
But are very serious problems that need to be addressed.
And that says a lot about your relationship with the patients, that they are having these very difficult conversations where they could definitely be in a position to be judged. I think on my side, unfortunately, because we have such a short period of time, sometimes it is easier for a provider just to give the medications than to sit in a room that feels so uncomfortable. Yeah. So what do you do from there? If a person tells you that they're experiencing these things, how do you go about the next stages of treatment?
Well, to me, regardless of the age of the patient, they have to be a part of the plan.
Okay.
You know, what's the next step? How would you like for me to help you? And I see them frequently. I see them often, only just to see their eyeballs, just to make sure they're okay. But they are part of the plan. You cannot come up with a plan that they're going to fail. So, you know, that may mean that, can you help me talk with my parents? Or it may involve getting a behavioral health person to come in the room during the office visit. But there's so little number of resources for LGBTQI youth, especially in mental health and behavioral health. So one of the things that I think will be really important for our group to learn about is that we need to increase access of care in medicine as well as behavioral health.
Sure, that's a great point. Hopefully now with technology changing, location doesn't become as big of a obstacle as it's been in the past. What other things do you think that we should be aware of as providers?
Just the importance of making sure that your practices are culturally diverse.
Yeah.
And that you get diverse training, cultural competency training. Because you may be that person that saves that person, but if they have any inkling that you're not going to be supportive and be disrespectful, they're not going to ever come back. We just really put emphasis on programs like the ones that the PA Foundation are doing in helping opening the awareness of these special populations. We're just going to have to give more testimonies for our patients and more education to medical providers.
Sure, that's a great point. So I think we do have to be a part of the solution when we're developing the plan, make sure that we're inclusive and have the patient take a major role in that, and maybe change the way that success and failure looks. If this plan doesn't work out, there's another one.
Yes, absolutely.
Okay, well, Deb, I could talk to you forever, but thanks so much for chatting with me and working with me on this project. I've learned a lot from you. Yeah.
And thank you too, Brittany. It's been amazing working with you.